Befavo and Precedex in conjunction with an infusion pump changed the entire surgical landscape.
We've been talking about doing this for a while.
For a long time. So,
well, thank you. Thanks for inviting me.
Right. Will, welcome. Just for our audience, we're just going to introduce ourselves. I'm obviously a general dentist in Las Vegas. I do some moderate IV sedation, utilizing midazolam and fentanyl. And I've been taught to do it using Bolus technique. You know, great teachers up in Portland, Ken Reed. And then I met you. You're a CRNA. You kind of like, you know, looked at the whole scenario and you're like, well, I'll let you tell the story, who you are and everything.
Yeah. Well, thanks for having me. It's good to be here.
Mm-hmm. Welcome.
Yeah. So, I remember we're coming up on 5 years here.
Yeah.
You and I.
Mm-hmm.
And I remember responding to an ad that you were out looking for a CRNA to come and help you. And that first day we talked, I saw the frustration in your face. I saw it in your body language that you were looking for a better alternative for sedation because you were doing a lot of big implant procedures.
Mm-hmm.
Yeah.
And I think what you brought to the table using an infusion pump and with the advent of a new FDA-approved medication like Befavo, remimazolam, it has, I think, really changed the way I practice sedation dentistry because, number one, it's reversible, but guys don't know how to use an infusion pump. I did not know how to measure and calculate. And not only that medication, but at the course that we teach, there's also the Precedex that you teach, and I think I showed you where there's people, you know, diluting Precedex and to little tiny syringes and still bolusing. And I think what you have showed us is how to calculate the dosage, the flow rate appropriately. Why don't you talk about that and what you saw?
Yeah.
And I was just doing bolusing. You looked and you're like, this is something could be improved.
Yeah. So, yeah, exactly. So I think that, well, I didn't really know a lot about how sedation dentistry was still being done because all of the dentists that I have worked with and gone into the offices, we were providing sedation the way that we would do that in an operating room or a surgery center operating room. So hospital operating room or surgery center operating room, which is, and we're talking about procedural sedation or moderate sedation. And it's true, the best way to do that is to have some type of an infusion device. And the ones that are usually used in surgery centers and operating rooms and hospital operating rooms are syringe pumps, infusion pumps, which is what we use now. We use the B-Braun pump that we've actually had we've had the two of those for about 5 years now, and they've been great. We haven't had any problems with those.
Yes. I call it the AI.
Yeah.
My AI machine.
Yeah.
Because you just put in all the factors in there.
Yeah, it's true. And, you know, you do kind of program it and then you just set it and you let it go.
And I've seen the old-fashioned ones with the dials and like on the side, there's like these cards. I never could understand it until you brought in that infusion pump from Braun, and it's been a game changer.
Well, there's a reason why that device you were talking about with the dials it was made for anesthesia, and I don't recall the company that was, but actually those were great.
Yeah, they don't make them anymore.
Yeah, they're and they don't even make parts to service them anymore.
That's true.
But they worked so well that they were used in every hospital operating room and every surgery center operating room to do infusions of drugs for surgery for a lot of years. Even like people loved them so much that you know they were still existing after there weren't parts being made anymore to even refurbish them with. But we've got a great solution, I think, and a great new device with particularly the B Braun syringe pumps I think are the best ones that are out there. But there's a couple of things you mentioned I think it's worth backing up and kind of talking about. So first thing is absolutely Bifavo, I think, is by all accounts, and it's a really great drug. We're still
safe.
Yeah, it's very safe. Its onset is very fast. Its offset is very, very fast. And if there's a situation where you have somebody that they, if unintended deep sedation, you can still give reversal. You can give flumazenol with it as well, and it will come off even faster.
I haven't had to face that because it's so rapid onset and
right. Yeah, we haven't actually. We haven't had anything even close to being like an emergency with that drug yet. But I think that we should even like step back and maybe talk a little bit about, I think that doctors would like to hear, like, there was a reason that you put an ad out. Like you were doing surgery, you were doing difficult surgeries and difficult implant surgeries with a lot of extractions and bone grafts, and even outside of the surgical procedure being difficult, you have some patients who are ill, like that we're having a population of people coming in for these procedures who have a lot of medical problems as well. So you seemed, when I met you, to be frustrated about the bolus technique and how people would keep waking up and that you had to stop and give them more medication, they'd fall back asleep again, and that this was a thing that was happening all throughout the procedure. It didn't create optimal operating conditions for you. It definitely wasn't the best way to do things for your patients, but all of the instruction you had in sedation, you were never even told. I mean, this was a big blind spot, right? You were never even told that there was another way to do it.
Yeah, I think when the professors are teaching, in all these mini residencies, the basic concept is bolusing, and you have to understand the drug and what it does, how it lowers the respiratory level, and you need to watch out for these things. So I think the infusion is something, the next level, that frees an operator from stopping, bolusing, and plus I think you have a nice, really, what we teach, the 3 phases in infusion pump. You got the initiation, you got the maintenance, and the emergence. And I feel it's kind of like a pilot, it takes off, and then the plane is coasting throughout your trip, and 30,000 feet up in the sky, right? The pilot is coasting and the plane is smooth. There's not a lot of bumps, and we as moderate sedations, we don't have that cruise control. And I think
one of my professors actually, that analogy about the plane taking off, reaching altitude and landing. It's an analogy that he used to teach us about induction, maintenance of anesthesia. Exactly. The induction being the takeoff.
Yes.
The maintenance being the cruising part, and then the emergence.
Descending.
Right. Yeah, the emergence is the landing.
And I look at it as well. And the use of Bifavo is so radical in its way that it's safe. You get a really nice effect with geriatric patients because, as you know, it's metabolized throughout the body through tissue esterases, and it's not just governed by the health of your liver or kidneys. So we've used it on people that I probably wouldn't have used midazolam for, but it was safe enough with Bifavo because it's such a rapid offset.
Right.
And people wake up alert. They're ambulatory. They are ready to. Some people, they're like, I want to drive home, doc. No. You're going to have a driver. But the effect of it, I would just say, is as good as propofol, where you have that nice onset and you can get to work and people come out of it less groggy. They're not as upset.
Can we stop there and talk about that bifavo propofol subject for a second. So we've been using bifavo, and we've been doing infusions with it for about a year now, maybe a little bit more. And I haven't seen much of a difference between bifavo and propofol as far as I think the effects are equivalent. Would you say so?
Yeah, and all the research that you in China and Japan, where most of it comes, they compare bifavo and propofol in oral surgery settings, and what patients experience, how they come out of the procedure. It's very, very similar.
Yeah,
and
actually and this is true of midazolam as well. If we're still comparing the two drugs, propofol and bifavo, the bifavo does not decrease the heart rate and blood pressure as much, so you really have a more
hemodynamic stable,
exactly stable hemodynamic dynamic status.
Yes,
even with pretty old and pretty sick people, which we've done.
Yes.
I know that one of our patients was 83.
Yeah. I actually had a recent one, an 87-year-old patient that I placed a zygomatic implant, and he was on a very low dosage of bifavo drip.
It was an infusion, right?
Yeah, it was an infusion. It was just amazing. The guy came out of it. He was happy. And I was so impressed with the effect of bifavo. And also the other drug that we teach in the course, Precedex, it is really good for longer procedures, but you have to know how it changes, how it lowers the blood pressure. So you do go over what to have an emergency toolbox, and I like that. We haven't had emergencies, although there's been stories where people mix up the steroids with the vial being so similar looking.
Right, and the name does. So we're talking about dexmedetomidine and dexamethasone.
Dexamethasone.
And if you have that in your drug box,
you can be very careful, right?
It might be easy.
The assistants don't give you the wrong vial.
Precedex or dexmedetomidine. I think that all sedation dentists should have the same tools that other anesthesia providers have to do moderate sedation with, and Precedex is one of those drugs, and it can be used safely if it's used how we teach it in the course. Yes. If it's used as an infusion, and you follow the dosing guidelines that are set up, because they've actually studied Precedex for procedural sedation, and that's exactly the protocol we've used for our patients here. It's the same one that we teach. And yeah, absolutely, I agree with you. There seems to be this subculture of drawing it up in a syringe and giving patients boluses with drug, and that was never something that was ever approved of by the manufacturer. It was never studied, and in my opinion, it should not be done, because I've seen I've seen when this drug first came out, and we were using it for sedation of intubated and mechanically ventilated people in ICU. Of course, they were sick, very sick people to begin with, but these people can get severely bradycardic. They can have heart blocks. There are some cases of asystole that have to be treated, and so most of those things can be avoided by avoiding bolusing the drug. And again, even in the clinical trials, the bolusing was always done off of a pump. It was never done by push. So it only stands to reason that if you're drawing that drug up in a syringe and you're pushing it into somebody, you're just setting yourself and the patient up for having those serious complications. But I have one question for you up front, going back about the why. So do you remember the first time we ordered the syringe pumps and we got them, we were there that first day? What And I remember like later, you know, like you had gone home and you were excited. You were like, I just had the best day, and it was such a great day. It was easy for me. The patients were asleep the whole time.
Yes.
It was just this calm, relaxed environment.
Yeah.
I was able to
Focus.
Right. Can you talk about so can you talk about going from the bolus technique that you learned to that first day where we did the first infusion, and what did that do for you as an operator? What did it do for the patient, and not just your operating conditions being better, but also you were more relaxed. You didn't have to, you saw that the patients were comfortable and not having to worry about whether they were going to feel pain and whether they were going to remember the procedure. So I'm asking because I think that a lot of doctors are still out there that were like you, that are just, they're frustrated, but they don't even know that there's a better alternative because nobody ever told them.
Right. So you're talking about when you came in and you observed my procedures for like full arch surgery, which could be from 2 hours to 3 hours. Some people require extractions, full mouth extractions, and you want these people to be not waking up, which I felt with the bolus technique, because we're waiting for someone to react and then you give them more. But this is like you're coasting really nicely. And so many docs go out to Brazil and they learn in Mexico how to do these very complicated surgeries, but what they don't teach is, like in these courses, is how do you keep the patient just nice and uniform throughout the procedure so you can focus. In this surgery, there's a lot of things that are happening, okay? You got to understand the trajectories of implants you're placing. Everything is like in your mind, 3D orientation of the jaw. You're looking at anatomy of people that are doing remote anchorage. You're aiming for the malar process of the zygoma. So everything's upside down. The last thing you want to do is drop everything and start bolusing people. So, and then the patients get upset, and I feel like you have to give them more to counter that they just woke up, and then you're waiting for this thing to get back. So the surgeries are more efficient. I would say you're more relaxed, and if the operator is relaxed, like the surgeon, then you do good work, right? And you're faster at picking up the parts and the multi-units, all these things. You're like a conductor of a big orchestra. You got the assistants, you're looking at the vitals, and so I think when you put it on auto cruise, I just love that it's on a stand, it's right next to me, and if the patient is getting a little bit more sedated, you just drop down the rate, which we teach, and you just see the after effect versus having so the skill set from going from a bolus technique to infusion, it changes your kind of observation even of the patient. You're not as more worried about it, and they're not as deep, where you have these peaks and troughs where they're waking up, they're upset. How come I'm not sleeping, doc? I mean, how many of us heard this thing?
Yeah, it's true. And then they think they were going to be asleep, and then they were awake.
Yeah, well, I paid you for this and stuff. So I hear less of that, and the students that we've mentored, most of them.
You just brought up a good issue. I'm sorry to interrupt you, but that I never thought about this part of it. That's so important for PR, right? Like somebody, like those people that even they're sedated and then they wake up and they get another, like that bolus technique is probably causing people to say, don't go to that. That guy said
the reviews.
The reviews, yeah.
And
that guy said he was going to sedate me and I was awake the whole time.
But most sedation dentists, if you look at their Google profile, they have very good reviews, because what are we using? Fentanyl, midazolam. I think overall, the course that we're teaching here, it's really to learn how to use Befavo, remimazolam, which we're so lucky to have FDA approve this medication, which came out originally from France, and then it got carried over to China and the Asian markets and Japan. They've been doing it a long time. And finally, I think it's a propofol killer. I think moderate sedationists should be so excited about the use of it.
You may be right. We're going to find out. It may be the thing that takes over propofol. So it sounds like you're saying, and I think it's important for all the doctors to know, that this infusion technique combined with remimazolam, Bifavo, and even Precedex infusion, it's creating much better operating conditions for you. I think that's one of the things that the doctors would really want to hear.
And I would say that just how digital dentistry, the capturing of things, have allowed us to scale up and create passive fitting bridges, long span bridges in zirconia. In the same way that stereophotogrammetry, and you've seen me use that camera, and the digital impression techniques, the same way that has changed the landscape of dentistry, you have exactly the same thing with Befavo and Precedex in conjunction with an infusion pump changed the entire surgical landscape, especially for those docs that are doing full mouth rehabilitation or like 2 to 3 hour full arch procedures, and they need a really nice smooth effect.
Right.
So overall, and you've seen how sometimes during this procedure you need to have somebody wake up, and Befavo gives you that opportunity to get that right bite. If we stop the infusion pump, within a couple of minutes they wake up and they're like, hey, what's going on? And sometimes these are pivotal moments where we need to capture a good bite, and then they go back to sleep if we're starting another arch. So I think overall it's revolutionary, but people need to know how to use it with respect to, is it milligram per kilogram per hour? Is it micrograms per, so you need to know what the research says, how to back up what you're doing. And a lot of what we teach comes from the articles that we've devoured and studied with respect to the infusion rates for both of these two medications.
Right. One of the things when you talk about that, and I thought of another, listening to you, I just thought of another thing that we should probably talk about, which is there seems to be like an urban legend about, okay, so we've got this infusion going, and isn't the drug building up, and aren't they going to get over sedated? And that's not really accurate. So I think we should talk about the fact that these drugs have been well studied. We know that within a certain dose range that's infusing, that it's very unlikely that you're going to overdose somebody or actually get to a point of really deep sedation or general anesthesia where you're creating like an emergency and airway problems. That really does not happen if you're doing this properly, like we teach in the class. And then the videos that over the years that you've shared with me, there's videos off of like YouTube with doctors out there that are combining fentanyl and midazolam and Precedex, and they're mixing all these different drugs together, like so
in one syringe.
We're and then I remember one evening you sent me this video, and it was a doctor that had was posting these videos about to other sedation dentists, and I said, look, I watched this thing. Within the first 30 minutes I was like, oh my gosh, like no nurse anesthetist or no physician anesthesiologist, we just don't do that in an operating room, in any operating room. We don't combine these drugs that way. It seemed very unsafe, and if it were, we would be doing that in hospital operating rooms and surgery center operating rooms all the time, and that dental sedation is not different in this respect. And I think that I feel like, we should warn our colleagues about that stuff that's out there and say, look, this is not how these
It's not appropriate.
It really is not.
Yeah.
And it's not safe, and it's not what we teach at all.
Yeah.
We will give proper instruction about the pharmacology of these medications, how the manufacturers intended them to be given properly so it's safe, and then people have adequate sedation. And it does work. You don't need to do these, like witches brews of stuff that's out there on the web, and that the majority of patients you have are going to do just fine. You don't need to mix up all these different medications together. And the few patients who are very difficult to sedate, then
you just need to call a dental anesthesiologist.
Right, you do what
you need to bring in some.
You pull the plug, and
you just need to bring in somebody that's good.
Yeah.
So I think the safety factor, and also remember, sedation dentists, and I practiced in like on a tiny island. I didn't even know what other forms of distribution of a medication that you can do, and you were very humble. I could see you were laughing inside, like on the stuff that we were doing with bolusing midazolam fentanyl, and it's basically like, who are we serving? Our egos, or is it like, so a lot of sedation dentists, they practice on these little islands, or the knowledge that we get is from like a face group, and you're just trying to see. But here in Vegas, they'll be able to first understand the theory, how Bifavo is different, why does it get broken down so fast. We talk about cases, and then after lunch, we do a live patient presentation, so you do see it in action. And I'm a visual learner, so the whole course has been kind of made so that doctors can fly in here. They get to see and experience what that entails, so that Monday you get started. And not only that, but I think because we have an audience now, we maintain our connection to our students, and I think you do a great job explaining. And
this
that's
group,
important.
This was like I think an unintended benefit of this thing is now we've got this growing
Community.
It really is
which is nice.
It really is a community now, and it's become something better than initially. It was just your idea that I think this is something, and I think that was really magnanimous of you to just say, you know what, this is, because you didn't ever have to, you didn't have to take the time to have, you're a busy guy, you've got young kids, and to take the time to have people come here, but you, like that day, I remember even kind of the look on your face, and you were like, you know what, this is something I think other dentists would like to, should learn, would like to know.
They need to know this. We need to teach them.
And now we have this group of guys, and it's become like a multifaceted, collaborative, like this working dental surgery anesthesia community, where we're not just sharing the sedation issues, but we're sharing things that are happening with patients and surgically and medically, and it's like optimizing people for surgery. So it's become this thing that's making the whole practice safer for the patients and better for the doctors, because now we're talking about things like how do we pre-op patients with certain medical conditions before we get them on the schedule when we're doing surgery. We're talking about patient management, like with potential complications that can happen during procedures. I mean, we're really, this is like an anesthesiology training program, really. It's the kind of things that take at least 3 years to learn, but it's becoming this ongoing, continuing education. Like, I really don't think there's anything else out there where dentists are getting this kind of knowledge sharing and experience. Like, I mean, I don't know that they'd be getting it anywhere else.
Yeah, a couple of things. The big meetings, the annual meetings, are really nice to network and listen to some research. And then you see some people selling courses that they're using very deep sedation drugs that you'll never use, and that's what I had problems with taking these courses. Is that as moderate sedations, we're never going to. I'm never going to use remifentanil, for instance, or like put them in such apnea that you have to like resuscitate them.
Right.
So I want to have I want to use medicine that I'm not going to be in trouble with, my licensing agency. I know that my staff feels confident in what I'm using. I am using reversible medication. I'm using a technique to deliver this medication safely versus bolusing, especially Precedex. And you don't get that in these big lecture halls. And you don't get it from the guys that are teaching so many medications that we'll never use because they just want to show you how to bag people. But I don't want to get to that point. I want to get to a point where, like, I want to feel comfortable with the medication that is legal in my hands and as a moderate sedationist, I can use. And it's enough. If there's something that's beyond moderate sedation, you shouldn't be touching it. You should call in proper trained dental anesthesiologists that have the airway experience, and no one should be practicing in the dark. So the point of this course is really to teach you two meds, which is Bifabo, which is radical, and Precedex, which again should be delivered through the infusion.
Yeah. We had, you just made me think of our Dr. Alam, Alex, our good friend Alex now, who came, you remember he came here on the heels of going to that sedation conference here in town?
Yeah.
So he said, I don't remember exactly, but I remember he was a little bit aggravated because he actually he brought his staff over here.
Yeah.
He paid a lot of money to bring these people this thing. And I remember he closed his eyes and he shook his head and he was just like, it was useless. Like, it was absolutely useless. I spent all this money, and then he's here with us for 2 days and he's like, this is like actually like I got a lot
It will
of
change your practice.
Absolutely. Useful information that I can bring back to the office on Monday and put it into practice, and it's going to make a big, it's going to have a big impact.
Well, you need the infusion
and make a big difference.
You need the infusion, assuming that he got it. So thank you for bringing this to our attention, all these beautiful, charming techniques. We appreciate it. And hopefully in this course, people can elevate their practice to the next level.
Thanks for having me.